Hello, this training has been developed for the nurses at Harlan ARH to provide an understanding of the Reverse the Cycle program and explain the nurse's role. My name is Dr. Tiffany Latham, and I am a senior behavioral health consultant with the Mosaic Group. The Mosaic Group is a nationally recognized consulting firm that partners with healthcare organizations to implement substance use response programs within their healthcare system. I am the primary consultant from the Mosaic Group who will be working with your hospital to implement this program in your emergency department. At the conclusion of this training, participants will understand the evidence-based reverse the cycle model being implemented at Harlan ARH on February 16th. Nurses will also understand the role they play within the reverse the cycle program when it comes to screening patients for risky alcohol and/or substance use during triage, and understand how to conduct the clinical opiate withdrawal scale for opioid-using patients. To understand the importance of having a program like Reverse the Cycle in your emergency department, I'll give you some background on why we are here. The Reverse the Cycle model is a comprehensive substance use response model that is designed to work in an emergency department and has been implemented in over 50 hospitals across the nation, including Hazard ARH, Whitesburg ARH, and Beckley ARH hospitals. As we look at substance use, we recognize that it is a public health crisis. I'll provide you some context here and share data on substance use nationally and locally in Kentucky. In 2020, there were 41 million people who needed substance use treatment based on their risky behavior, whether that was alcohol use, prescription misuse, or other illicit substance use. However, only 4 million of those Americans were receiving treatment, and those that did not receive treatment haven't received it for a number of reasons, including barriers such as childcare, transportation, and health insurance. But what we find even more so is that many of those patients did not think they needed treatment. In the same year, there was over 59 million Americans who had tried an illicit substance in the last month, and an estimated 100,306 Americans died from a drug overdose, which is nearly a 30% increase from the previous year. As we shift now to looking at opioid-related emergency department visits and inpatient visits, as we were beginning to see some decrease in opioid-related hospital use in 2019, moving into 2020, effects of the COVID-19 pandemic contributed to the stark increase seen here in emergency department visits and inpatient stays over the last year. When it comes to drug overdose deaths, our nation was hit incredibly hard in 2020. According to the CDC, there were 100,306 drug overdose deaths reported in the United States last year. Roughly 69,000 of those deaths were attributed to opioid overdoses. The number of deaths attributed to overdoses in 2020 is a somber reminder that the opioid epidemic continues to deeply impact our communities. The Office of Drug Control Policy believes the global pandemic caused by COVID-19 was a major contributing factor to the rise in overdose deaths across the United States and in Kentucky. Kentucky is among the top 3 states for the spike in overdose deaths in 2020. The interruption of routine care for those in recovery, the sense of isolation, economic concerns, and anxiety all contributed to the dramatic increase recorded. The data displayed here on Kentucky resident drug overdose deaths was produced by the Kentucky Injury Prevention and Research Center for the Kentucky Department of Public Health in 2021. Data are provisional and subject to change. Here we see January 2019 to March 2021 data. According to the report, at least 1,964 Kentuckians died from drug overdoses in 2020, a 49% increase in drug overdose deaths from 2019. In addition to the stress caused by the pandemic, reports show the increase in overdose deaths for 2020 is due to a rise in illicit fentanyl. Fentanyl and methamphetamine have been identified as the biggest drivers of overdose deaths. For 2020 data, toxicology reports show that fentanyl was involved in 1,393 of the overdose autopsies, or approximately 71% of all overdose deaths for the year. Acetylfentanyl, another version of the drug, was found in 502 of the cases. Taking a look at state level data here, we see now that the national data aligns quite well with what played out in Kentucky from January 2019 to December 2020. We see fentanyl-related drug overdoses began to ramp up early in 2020 and hit quite a spike in May 2020, and has since then maintained high counts since that spike. Taking a closer look at the local Harlan area in 2020, Harlan County had nearly 55 drug overdose deaths per 100,000 population. Now you might be wondering, what can be done to confront this crisis? I will now move on to providing an overview of how the Reverse the Cycle program addresses the national substance abuse epidemic we are facing. The Reverse the Cycle model is a comprehensive substance use response program. Harlan ARH has received funding from the Mosaic Group through an award from the CDC to implement the Reverse the Cycle program in your hospital. There are 3 components of this program. One is universal screening and peer intervention. Next is the Overdose Survivors Outreach Program, also known as OSOP. And then there is the initiation of medication for opioid use disorder in the emergency department. Now I will walk you through how Reverse the Cycle will be integrated in your existing workflow in the emergency department. The Reverse the Cycle protocol has been approved at system level by leadership across ARH. This protocol includes having all emergency department patients ages 18 and older being screened by their nurse during triage. The screening tools are located in Meditech and include a series of questions to use to determine a patient's risky substance use as it relates to alcohol, prescription drug misuse, and illicit drug use. If a patient scores a 7 or greater on the audit C, which is the tool used to determine risky alcohol use, and or answers yes to either of the 2 drug questions asking about a patient's prescription or illicit drug use, they will be considered a positive screen. There are also what we call exclusion criteria that will result in a positive screen, which I will share with you on the next slide. The screening tool that you will use to understand patients' alcohol and drug use is called the Adult SBIRT screening. To access the screening, it can be found within the triage section of a patient's chart or within the patient's work list. Here's a screenshot of the SBIRT screening. What you see first at the top are called exclusion criteria. Some patients may meet the exclusion criteria during the triage process. These fields will be available for you to click on if a patient meets this criteria. You will select none if the patient does not meet any of the exclusion criteria. For patients who are less than 18 years of age, they are not eligible for the screening. If a patient is experiencing significant and distressing symptoms as a result of an acute psychiatric illness that requires immediate treatment, their current symptoms prevent them from being able to process and comprehend what is being asked. So they will be excluded from the screening. If a patient is critically ill, so they have presented with life-threatening symptoms or conditions, they will be excluded. A patient's presentation of intoxication indicates they are under the influence of alcohol or drugs, and their condition impedes their ability to answer questions. If a patient is nonverbal, they're unable to communicate in a way that would allow for adequate assessment, they would be excluded. If a patient opted not to answer screening questions, you would select patient refused. If a patient presents as an opioid overdose and responded positively to Narcan administration, or there were evidence of opioids as reported by EMT or patient presentation, you would select suspected opioid overdose. Patients that present as an overdose with no evidence of opioid use, you would select suspected overdose. Provider request would be selected if the patient is unable to answer questions or provide answers that do not result in a positive score, but you as the nurse or the emergency department provider would like to recommend the patient receive an intervention, you would select provider request. And if a patient is accompanied by the police, you should select police custody. After you have identified whether a patient meets exclusion criteria, then you will move on to asking the Audit C questions and substance use questions. The Audit C contains 3 questions related to alcohol use. On the Audit C, a patient can score between 0 and 12. For patients who score 7 or greater, this will trigger a positive screening and the patient will receive a brief intervention with a peer recovery coach. A brief intervention is a conversation with patients about their substance use to determine their motivation to change their behavior. Each of these questions should be read to the patient as written. You should not use any other language than what is written. This will allow for getting the most accurate response from patients. If you ask a patient these questions and they do not give you a direct response, read the available response options and have them state which one matches the best with their alcohol consumption. Following these 3 alcohol use questions are 2 questions that ask about a patient's drug use. If a patient responds affirmatively by saying yes to either of the drug questions, they will receive a brief intervention with a peer recovery coach. These next 2 slides include descriptions for each of the exclusion criteria that we just covered. This visual here shows an overview of the peer recovery coach's workflow. A peer recovery coach is somebody who is in long-term recovery, and they are employees of ARH that have been designated to meet with substance-using patients who present to the emergency department. They have been integrated into the emergency department to provide support and help patients get connected with resources in the community to address their substance use and other areas of their life. It starts with all emergency department patients ages 18 and older completing substance use screening with the nurse. If the patient screens positive for risky substance use, the peer recovery coach will receive an alert, Meditech, that a patient with risky substance use will need to be seen. The peer recovery coach will review the patient's results on the screening, review medical history, and understand the reason for the patient being in the emergency department. The peer recovery coach will then meet with the patient to have a conversation and provide a brief intervention. Based on the conversation the peer recovery coach has with the patient, they will develop a plan in collaboration with the patient. This plan can be anything from a referral to a substance use treatment program, a plan developed around reducing use, or receive referrals for resources in the community such as food, clothing, housing, and transportation. If there are patients who will not answer the screening questions, but you suspect they may use or drink alcohol at risky levels, or their results on the screening are negative, but you suspect they may use or drink at risky levels, you should select provider request. And this will trigger a positive screening for the peer recovery coach to meet with the patient for a brief intervention. The foundation of this program and the individuals who will be working with patients in the emergency department to support them with their substance use are called peer recovery coaches. As I mentioned, peer recovery coaches are individuals in long-term recovery from addiction that are trained in motivational interviewing and other skills to use their lived experience to help patients in active addiction. They are also referred to as peers or coaches. When the program goes live on February 16th, there will be 1 peer recovery coach staffed in the emergency department Monday through Friday from 8 a.m. to 4:30 p.m. This peer will be an asset to your team by providing patients with resources and completing referrals to treatment. The next component of the program is called the Overdose Survivors Outreach Program. Patients who come into the emergency department following an overdose are eligible for the Overdose Survivors Outreach Program. Patients in the OSAP program will receive ongoing community outreach from the peer recovery coach for 90 days to prevent a subsequent overdose. They will also be connected with community resources and treatment programs. The patient will be seen by the peer while they are in the emergency department. The peer will provide the patient with overdose prevention education, discuss the risk of having a subsequent overdose, and then follow up with them in the community within 24 hours of their discharge from the emergency department. The last component of the program is the initiation of medication for opioid use disorders. Mosaic has implemented the Reverse the Cycle program in hospitals across the nation since 2014, and it has been about 5 years since we have been working with hospitals to provide a dose of Suboxone to patients who present to the emergency department as opioid using and report motivation for treatment. ARH has a system-level protocol that has been approved by leadership, permitting patients to receive an initial dose of Suboxone while in the emergency department if they meet clinical criteria. Next up, I'm going to share with you an overview of this portion of the program. If a patient presents to the emergency department as opioid dependent and they are motivated to continue using Suboxone upon release from the emergency department, the peer would communicate this to the nurse and provider, and the patient would then be assessed by the medical team. There's a great deal of research and science that supports medication-assisted treatment for opioid use disorders, that it does save lives. Patients who begin experiencing withdrawal can receive an 8 milligram dose of Suboxone and begin to feel better, allowing them to understand their discharge instructions better. They're less likely to leave AMA, and they are more motivated to attend treatment the following day. Patients who receive a dose in the emergency department are also less likely to use opiates before their treatment appointment. To explain how Suboxone works, it does have a ceiling effect, which prevents a patient from getting high. It also is formulated with naloxone, which includes a blocker that prevents an opioid effect if a patient does try to use it for the purpose of getting high. If the patient agrees to go to treatment the following day, the peer recovery coach will notify the provider that the patient should be considered for a dose of Suboxone. Providers will determine if the patient is approved for Suboxone administration in the emergency department. If the patient meets criteria to receive a dose, the provider will place an order for the opiate withdrawal scale. If a patient scores 8 or greater on the clinical opiate withdrawal scale, the nurse should notify the provider. The provider should then order 1 Suboxone, 8 milligram sublingual tablet, and any additional medications to support the patient in withdrawal via the order set. The emergency department nurses should administer the medication and observe that it is taken in the way the patient has been educated while they're in their emergency department. If the patient receives an 8 or greater on the clinical opiate withdrawal scale, then the patient will then further be considered on their clinical appropriateness to receive the dose. The patient will then be scheduled with what we call a fast track provider for continued induction and maintenance. A fast track provider is a physician in the community who will continue working with the patient while they are taking the medication. The providers are considered fast track because of how quickly the patient is scheduled with them after receiving their initial dose in the emergency department. When a peer has recommended the patient be considered for a dose, there are some exclusionary and cautionary criteria the provider should consider. For exclusion criteria, if a patient reports they are on long-acting opioids for pain, if there is any evidence of liver disease, or if the patient is in any acute psychiatric distress and unable to consent to treatment, then we would not have the peers recommend that the provider consider them for a dose. Or if the patient reports any allergy to buprenorphine or naloxone. We also want providers to proceed with caution, but not exclude the patient entirely if there is any prescribed or illicit benzodiazepine use, or if the patient is pregnant. Neither of these disqualifies the patient, but we do want to make sure you feel confident that the patient should be considered a dose from there. The clinical opiate withdrawal scale is a method of recording scores for various symptoms of opiate withdrawal. An assessment used to determine the level of withdrawal for a patient who's using opioids. It's used in healthcare settings for patients who have received opiates for the treatment of pain and is showing adverse signs of opiate withdrawal as a subsequent result. It also advises clinical needs for induction of Suboxone. The sum of the numbers determines the level of opiate withdrawal and can help determine the next course of action for a patient. Nursing will be notified if the clinical opiate withdrawal scale needs to be completed for consideration of induction. Here we have a screenshot of the opiate withdrawal scale for your viewing. This allows for quantifying the severity of a patient's opiate withdrawal. Things you will observe in the patient include their resting pulse rate, sweating, pupil size, and several other signs and symptoms of withdrawal. When giving patients an 8 milligram dose of Suboxone, we have not seen a high rate of precipitated withdrawal occur, but we do know withdrawal is more likely to occur when there is a level of physical dependence that is high, or there has been a short time since the patient's last opiate use, or if that initial dose of buprenorphine was too high. So again, that is why we do the clinical opiate withdrawal scale, to make sure they are far enough into withdrawal that we might prevent precipitated withdrawal as we look at that exclusionary and cautionary criteria. If the patients happen to go into precipitated withdrawal after you have administered that first dose, we recommend that you give a 4 milligram dose to the patient in addition, so that in order to try and prevent or end their precipitated withdrawal. When instructing a patient, it's important to make sure they understand how to take the medication, the purpose of the sublingual absorption, not taking other substances or engaging in talking or smoking. That will also impact absorption. It's important that they understand that they should keep the tablet under their tongue and that they should not swallow until the entire tablet has been dissolved. There should be no smoking immediately before or after. There should not be any consumption of acidic drinks, and patients should start with a moist mouth. While the provider and nurse are working on administering the patient's dose, the peer recovery coach is arranging for the patient to be referred to a fast track provider. Fast track providers are an existing network of community providers Mosaic has worked with that have committed to receiving patients from Harlan's emergency department after they have been dosed. These providers are ready and willing to accept patients from the emergency department the same day or the next day for continued maintenance. Each fast track provider has a unique protocol the peers will follow to schedule patients an appointment. The peer recovery coach will not recommend a patient to the provider to be considered for a dose unless the patient has confirmed they will attend treatment and there is likely an available appointment the following day. A few confirmed fast track providers for Harlan include Sparrow Health, Bright Heart Health, and H&A Counseling Associates. In summary, if a patient presents as opioid using and motivated for treatment after discharge, they will be assessed by the medical team with a clinical opiate withdrawal scale to determine clinical appropriateness to receive a dose. And if permitted, the patient will then be fast-tracked to a provider in the community who will continue induction and maintenance. That completes this training. The Reverse the Cycle program will be going live at Harlan on February 16th. Tiffany Latham, who is a senior behavioral health consultant with the Mosaic Group, is the primary consultant working with Harlan ARH to support this program. She will be providing in-person and remote technical assistance to support the peer team, to support the nurses and the providers as well throughout this process. Her phone number and email are listed here if you have questions. Thank you so much for your time. Please reach out to Tiffany with any questions you may have. Have a great day.